much. I'm really appreciated being invited back here and getting to speak between Steve and Ahmed is a real pleasure. I really enjoyed working with them when I was at Boston Children's. We're going to talk about the venous anomalies in the KTS. And what I'd like to do is review the normal venous anatomy in the legs, some of the imaging that we use for looking at veins, give you an overview of KTS spectrum, and then describe it in a fair amount of detail what kind of anomalies we see in the lower extremity veins and also in the abdominal veins. So I'll show a few slides just showing the spectrum of Lipochanani syndrome, or as we prefer to call it, capillary lymphatic venous malformation. Here you can see the capillary stain. You've seen a lot of examples about it, lymphatic vesicles, which can be very bulky or just represented by these little tiny blebs. Venous malformations that you can see through the skin as varicosities, and usually some overgrowth of tissue. Here's a close-up of some of those lymphatic vesicles. Here's a patient who has more extreme involvement of the anomalous veins and less overgrowth and lymphatic component. Here's somebody who has capillary stain, has some anomalous veins, and has tissue overgrowth. So this overgrowth is probably more in the realm of fatty tissue and lymphatic cysts. This patient has bilateral disease, and this one has more lymphatic component, and two more patients. So these cases really just show the spectrum of different components of tissue overgrowth, lymphatic disease, venous anomalies, and so forth. But when I image the lower extremities, quite often I see the same kind of venous anomalies. Here's a couple of additions to the spectrum. I used to wonder, should we call these a localized KTS, or certainly they do have capillary malformation, they have lymphatic malformation, and quite often, again, they have the same kind of venous anomalies that we see with KTS. Another example is this disease that's mostly above the knee, but it looks kind of similar. Capillary malformation with overgrowth of the leg is often called KTS, even though there's no lymphatic component, and the venous anomalies can be similar as well. Flow syndrome, you probably see more of that with Dr. Almari's talk, but we have venous anomalies, we have lymphatic anomalies, we have a lot of tissue overgrowth, and now recently we've seen that it's really the same defect, be it in all your cells or just a few of your cells, that cause all these problems. So that probably explains why the venous anomalies are so similar. This is a condition I'm not talking about. Diffuse venous malformation is caused by different mutation and has different venous architecture. So I want to just take a second to acknowledge that I don't draw very well, but I think drawings or diagrams are often the best way to explain anatomy to a patient or another doctor. And so I've tended to use diagrams that other people have made and just kind of change them. But here's normal venous anatomy, roughly portrayed, and we have a series of veins running in a vertical fashion up the inside of your calf. They run between the muscles next to the arteries, and they collect here at the level of the knee into what's called the popliteal or knee vein, and then it continues up as the femoral vein, and then it becomes the external iliac vein, common iliac vein, and goes back in the inferior vena cava toward the heart. And other normal components are the main superficial vein, which goes from your foot all the way up to your hip, in the fatty layer between the muscle and the skin called the greater saphenous vein. We have a lesser saphenous vein that kind of connects to the knee vein, and we have some deep femoral veins here. So these are all the veins that people with normal venous anatomy would have and would show up on imaging. And here's a venogram that I'm going to go into a little more detail about how I make these, but it shows the deep veins here. This one's called the anterior tibial. And then we have the perineal and posterior tibial. They come into the popliteal or knee vein. And then the femoral vein, the fundifemoral is this little faint guy behind it. Common femoral, external iliac and IVC. And then we have the superficial veins here, the short saphenous or lesser saphenous, and the long saphenous coming up here and then connecting up just below the hip. What I'd like to draw your attention to is how nice and smooth these veins look. They're smooth walled. If you look really closely, I'll show you some pictures. You can see little valves interposed every few centimeters, and that differs from what you see in KTS. This is the diagram I photocopied a few decades ago, and I've actually forgotten whose it is. I'm hoping it's not Peter's, but if it is, sorry. I'm sorry, I kind of butchered it up too. But so here you can see the in the kind of straight lines, the normal veins, the deep veins, superficial veins, and then in the kind of hatched-in shading, you can see the veins that are most commonly seen in KTS. And these include the marginal vein here. It runs often all the way from the lateral marginal vein of the foot, all the way up the calf, the thigh, and then it enters into the deep circulation through a variety of routes. And one of the typical ones is a vein that runs in the back of the thigh. It's called the sciatic vein because it runs very close to where the sciatic nerve is. And so that marginal vein can connect with the central veins through a variety of pathways. Now, these venous anomalies are typically valveless. They don't have the valves that you see in the normal veins, and so they become incompetent. And that means that when you stand up, the valves usually prevent the blood from going backwards. But when you don't have a valve, then when you stand up, the blood can literally go from the main vein in your abdomen all the way down and pool into these. Why is that important? Because it can cause swelling, it can cause increase in the venous pressure, and it can result in stasis of blood and blood clots forming. Now, these venous anomalies are quite common too. In fact, Dr. Levitsky's done quite a bit of work describing the fact that even if they look fairly normal, they often don't have normal function. And so I've been really interested in the way they look, being an imager. But what we do see are interruption, absence, hypoplasia. I know Dr. Almar thinks they never actually absent, but sometimes segments of them are so small that they really don't function. Another anomaly we see quite commonly in the deep veins is the dilated central drainage. I'll show you some of that. We also see incompetent perforators quite often. So perforators are little connections between the deep veins and the superficial veins, and normally the direction of flow is from the superficial veins into the deep. But when they, again, are incompetent, then the blood will go from the deep veins to superficial ones, and that will show up as varicosities. I'm also going to show you another example of portal venous anomaly. So here are some of the sequelae that we've talked about. Venous insufficiency causes pain, it causes orthostatic hypotension if it's severe, that is when you stand up. So much blood goes down into them that your blood pressure drops, you become faint, you can pass out. Venous insufficiency can cause rectal bleeding when it's in that location, and then we can get pain and pulmonary embolus, portal vein thrombosis due to the clotting in these veins. How do we image them? Well, there are a few techniques. We usually start with an MRI. And we've recently got improvements in MR angiography. It shows the anatomy quite well. But if I really need to know what connects to what and how well they function, I like to do contrast venography just before I do the treatment, and I'll show you that. So MRI, these are standard images. In this sequence, everything that's bright has fluid in it, blood, and the flow is very slow. So here you can see in this right leg, you can see this deep vein, the popliteal vein. You can see this normal saphenous vein. And here you see the marginal vein, which is kind of large and straight in this young child. Over time, as the person gets older, they get more and more tortuous and wiggly. You see in the normal leg, the uninvolved leg, the superficial veins are really pretty small. At the level of the pelvis here, you see, not too well, but you see femoral vein is present on the right. On the left here, you see quite a large iliac vein. That's one of the deeper ones. And here you see some of the anomalous veins, the sciatic veins, posteriorly. So the sciatic veins aren't in the same plane as the other, the deep veins. Another MRI showing when you use contrast. This is without contrast. You see a lot of white things. With contrast, it shows you that this thing enhances. That's your sciatic vein coming in at the back. These things don't enhance. They don't take up contrast, and they're the lymphatic malformation. And here you can see this patient has a femoral vein as well as the sciatic vein. More examples. Here you can see normal femoral vein on the normal side, and on the abnormal side, anatomy is different, and you have a big marginal vein coursing through here to a sciatic vein. Below the knee, you see the rest of the marginal vein here. And you can also see the deep veins are not quite nice and normal and straight like they should be. Now, there are two types of MR venography. This is the old type called 2D time of flight, and it gives very good pictures, but it's flow dependent. And so if you have a picture like this where you see marginal vein on each side, but you don't see the deep veins, you don't know if it's real that there aren't any deep veins or just because there's less flow in them. So now, most of the time when we're looking at veins, we do what's called a contrast enhanced or time resolved MRA, and here you see on the late images, you still see a little bit of contrast in the arteries, but then you also see the veins. So this reason I showed the two, which look very similar, is to show that the techniques have improved, the images have better resolution now in this older person, but also that imaging an infant is much easier than an adult because you can see all the anatomy in one imaging coil. So here, if you look on the right, you see two lines side by side. One is contrast still in the artery and one is in the vein. You see the normal saphenous vein, and on the affected side, you see the marginal vein coming up here, and you see some deep veins here. You see artery and vein here, and then in the mid-thigh, you only see one line. And so for me, it's still very difficult, even with contrast-enhanced MRA, to be sure about this femoral vein, whether it's really there or not. So I've been using step table venography, and that's an X-ray technique where we actually inject contrast in the veins. We put an IV in the foot. Sometimes we have to actually put an IV in one of the deep veins, and we use a contrast injector to inject quite a large amount of contrast from the foot to the pelvis, and the X-ray equipment does the rest. So these are the different steps. We have to image one area, and then another, and another, and another. And I just kind of mechanically put these images together to show the whole system. But because we're following one contrast bolus, we get less artifact than other methods. But here you can see again these nice, slender little deep veins, femoral vein here, nice normal saphenous vein. And here on the other hand are images from a patient with KTS. This is the injection in a foot vein, mostly filling abnormal superficial veins. So in this case, we have to put a second IV into one of the deep veins, and now we see that the deep veins are in fact present. So just an anatomy of the flow of contrast or blood in the foot and in the calf. And basically when we put the contrast in one of these veins, it goes up the saphenous vein and also deep into the plantar vein and then into the deep veins. So we usually fill the deep and superficial veins at one time. The equipment takes images at each of the levels, and then the X-ray equipment starts from the beginning again as you inject the contrast, and it subtracts the bones from the contrast. So all we get are these nice little lines. So contrast going from a foot vein into the saphenous vein first, and then finding some of the deep veins. And these are now the different levels. Here's the foot, here's the calf, here's the knee and thigh area. And we have really good uniform filling of all the veins, so I like this technique. But this is what I was referring to. If you look at normal deep veins, you see all these little valved areas every centimeter or so in the deep veins, and less common, but still present in these superficial veins. And just notice this nice, smooth, tapering shape of the femoral vein. So that's again a normal. And now if you look at the venograms in people with KTS, you'll see quite a variety of other abnormalities. Here, for example, marginal vein with no valves in it. And what I've noticed is that the deep veins, when they're present, they can be really small, like this patient. And even when they're present and decent in size, they have a funny shape. They kind of have this big area right above the knee, and then it gets a little smaller again and so forth. So interesting to me. A lot of times you have just a myriad of extra veins running between the muscle to the skin. So here's just a description of these venous anomalies. We have this persistent marginal vein. We have deep vein anomalies, interruption, absence, hypoplasia, dilated central drainage, incontinent perforators, and portal venous anomalies. So here's our marginal vein anomaly coming up on both sides in this patient. And what I've done now is I've taken Dr. Glowicki's diagrams and just tried to show what the anatomy is here. This is another marginal vein. I think this image shows really well if there aren't any valves in it. And it comes up. So here we have marginal vein coming all the way up and then joining the femoral vein. So this one's crossing in front of the thigh and going the relatively normal route. Here's another marginal vein you can see in the MR images. And then on the venogram, again, no valves. And now we're seeing the deep veins, popliteal vein with this really abnormal little valve, and then that widened spot, and then it just looks kind of like a rigid little pipe going up there. And here's what we have. We have the deep veins are present, but not quite right. And then we have these marginal veins. More anomalies. So here's a marginal vein, and you can see all these connections into the muscle and into some of the deep veins. And here's another vein that's connecting the deep veins from the calf to the thigh, and it's running in a squiggly fashion through the quadriceps or hamstring muscles. Now, we have a marginal vein here, but instead of crossing over to the femoral vein, it's crossing over at the level of the buttock and going behind the hip and up into the normal drainage. Here it is on the diagram, going behind the hip, but joining the iliac system. Another anomalous vein, and this one is running right over the femur. This is a sciatic vein. It's running the same course as sciatic nerve and coming up into the inferior vena cava. You can see how large this is. And on the diagram here we see it's running right along the middle of the back of the thigh and up and into the internal iliac drainage instead of the external. Now, some patients, this is probably what you'd call a capillary malformation with some overgrowth and venous enlargement, but you have the varicosities on the inside of the calf instead of the outside of the calf. So here we're seeing on our venogram that this is actually an abnormal looking greater saphenous vein. And when we look at the deep veins, they're a little bit funny looking too, just like the other patients I showed you. And we have these abnormal perforators here. So here's the diagram. This time we have a big saphenous vein, and we do have a deep vein. All right, another example showing that you can have a marginal venous anomaly here and also have abnormal saphenous vein. So here we have a marginal vein, big varicosities around the knee, big connector gluteal vein, and then also very abnormal saphenous vein and a relatively small femoral vein. More and more bizarre things can be seen. This patient has similar veins to the other KTS patients, has relatively small femoral vein, but also has these really strange low flow malformations. You might even think it's like FAVA, fibroadipose flow syndrome, very large and abnormal looking veins in the chest. On the MR angiogram, you can see these veins here filling from the jugular veins, the left arm vein, and we probably had some thrombosis in the right arm vein. Inject contrast here, you see how abnormal looking this scapular vein is. Just another example of anomalies. This patient has pain in his leg and swelling. We know he has lymphatic component, probably had some cellulitis. But we looked at his veins. Here we see the big marginal vein, but we also see these little bridging or perforator veins here. And the reason these, I like to show these, is they show how some of these dysfunctional channels affect the circulation. When we put a catheter in the deep vein here, it goes up one deep vein. Instead of continuing up to the heart, the contrast comes back down the other deep vein, so it's going backwards in the calf, and then through these perforators into the marginal vein. And this is after closing the marginal vein. Now you see the deep veins better. You see that it's just not quite normal, but the flow at least is in the right direction. Another patient, a very young one, marginal vein, tons of veins in the buttock, and a big sciatic vein here. And when we close the superficial vein, we see the deep veins are present, but they're really small thread-like channels. Other locations can have similar anomalies. This patient has a capillary lymphatic lesion only in the hip area, but she has symptoms related to thrombosis of these abnormal veins. And so these are quite amenable to closing them. You can see this big clot that formed on this ultrasound study in one of those veins, responded to Lovenox, but kept coming back. And this is what they look like with contrast in them. Rectal varicosities. This patient has typical venous anomalies of KTS, but has some big veins also in the wall of the rectum. And here's an interesting patient. She's the one I showed you initially with these huge superficial marginal veins. The diagram here, she actually didn't have femoral vein, but was operated on. Actually, Steve took out this big marginal vein because we were worried about it clotting and sending pulmonary emboli. And then when we studied her better, we could see there were deep veins. They're not normal, but continue up in her sciatic vein. Look at how big her inferior vena cava is. So when she showed up again at 18 years of age with pulmonary emboli, we couldn't actually put one of our filters in there to protect her from more emboli. We had to put it lower down. She had a few episodes of pulmonary emboli, but then seemed to be stable on constant anticoagulation. She had a pulmonary angiogram at about 22 years of age when she developed severe limitation of exercise ability. Was short of breath just walking upstairs, and we found that these pulmonary emboli had damaged the circulation. She has a lot of blockage of the arteries in the lungs, and so she actually underwent a surgical procedure to remove those clots. But before the surgery, she had a full body workup for venous anatomy. Here you see those abnormal veins coming from the leg. You see some funny veins in the pelvis there. And when you do an MR angiogram of the abdomen, you see the arterial phase here, and you see this huge vein, which looks a lot like the one Dr. Fishman showed you. And so on questioning, yeah, she did have rectal bleeding, but she'd learned how to manage it. She didn't complain about it a lot. So we took her to the angio room. This is an angiogram of the bowel, small bowel. You can see the veins here coming and moving in the right direction toward the liver. But then when you wait a few seconds, you see this other big vein faintly filling downward. And here's a blow-up of that, showing the veins from the small bowel, and then this big colonic vein going downward. And when we studied the colonic veins, we confirmed that. And not only did this vein go to the rectum where it's causing bleeding, but then it drained into the infravena cava, and it was probably the cause for the pulmonary emboli. So, in summary, we do have venous anomalies in KTS that involve central veins, superficial veins, deep veins, and portal veins. And it's a good idea to have them imaged young if possible to just know what is present. And then going forward, before we treat them, we can image them in a lot of detail to know what we're dealing with. Thanks for your attention.